Welcome to this DermNet e-lecture on blistering disorders. Over the course of this talk, we will be introducing the concept of vesicles and blisters, their definitions, and go over some of the causes of blistering and outline their treatments. So how is a blister defined? Well, a blister is a disruption of the layers of the skin resulting in a fluid-filled skin lesion. Blisters can be subdivided depending on a few different factors. For example, their size. Vesicles are less than 5 mm in diameter, whereas bullae are more than 5 mm in diameter. It is important to remember that vesicles can coalesce and form blisters just by the nature in which they join together. We can also describe their position, for example intraepidermal, below the granular layer, subdermal or dermoepidermal junction. We can also describe the mechanism by which the blistering occurs. For example, metabolic blistering conditions such as porphyrias, autoimmune such as pemphigus and pemphigoid, and mechanobullous, where ease of blistering is due to the relatively minor mechanical traumas seen in, for example, epidermolysis bullosa. Dermatologists love blisters. Their cause is usually apparent, but it may involve some detective work and a few investigations. So here's a surgical sieve of the causes of blistering. The areas highlighted in red will be discussed in more detail later on. There are congenital or genetic disorders. Now this is a group of relatively rare conditions which can be absolutely devastating, including a condition called epidermolysis bullosa. We can also see vascular causes of blistering, so we can get vasculitis where the inflammation is sufficiently severe to cause blistering. Relatively common causes of blisters would be infective causes, so the staphylococcal infection in impetigo may blister. We can see blistering if the inflammation is significant enough in cellulitis or necrotizing fasciitis. We can also see blistering due to viral conditions such as varicella and herpes simplex virus. And occasionally we do see blistering due to fungal infections. Obviously we see blisters due to trauma. This can be mechanical trauma, chemical or thermal. There are autoimmune blistering conditions as we've already discussed, including pemphigus, pemphigoid, and there are metabolic causes of blistering including the porphyrias. Sometimes we can see iatrogenic blistering, which is induced where we treat skin lesions, for example with cryotherapy, and that's a relatively unwanted side effect. We see drugs and other photoactive agents producing blistering, for example in a fixed drug eruption, Stevens-Johnson syndrome, and toxic epidermal necrolysis. We can see psychological conditions producing blistering occasionally, for example in dermatitis artifacta. And then we can see inflammatory skin conditions that may blister, occasionally in lichen planus and lichen sclerosus. Most of us will have developed trauma-induced blistering, for example on a long walk in a new pair of shoes. Here, friction has caused blistering. We can also see blistering induced by UV light, for example in severe sunburn. Other causes of blistering include burns, either due to extreme heat or extreme cold. Exposure to chemicals can also cause blistering. With trauma-induced blistering, the cause is usually apparent on the basis of the history. Treatment of trauma-induced blistering depends on the cause. For example, irrigation may be needed in chemical burns. For thermal burns, first aid measures are important to stop the burning process by limiting thermal damage. On admission to hospital, appropriate analgesia should be used and IV fluid replacement as needed in order to balance losses incurred during the burning process. We may progress to referring for surgical management, which may include debridement of necrotic tissue, skin grafting, and can result in repeated trips to theatre. Infective causes of blistering can be broadly split into bacterial, viral and fungal infections. Our bacterial causes of infection would include necrotizing fasciitis, bullous cellulitis and bullous impetigo. Viral causes of infection include herpes simplex, herpes zoster and varicella zoster virus. Fungal causes of blistering are much less common but can occur. Here's a fairly typical example of bullous impetigo. This is a staphylococcal infection, but the infection is caused by a phage-type Staph aureus which releases an epidermolytic toxin. This produces superficial intraepidermal blistering just below the granular layer. So the blisters develop, but because they're so superficial, they rupture relatively easily, resulting in erosions which are often covered with honey-coloured crusts. Staphylococcal scalded skin syndrome, fortunately, is a relatively rare type of extensive blistering that will occur due to a distant staphylococcal infection, sometimes of the throat or more often of the skin. There is a large production of epidermolytic toxin, and what happens is that the toxin produces fairly rapid and extensive erythema, followed by subgranular blistering over large areas of the skin. You can see in this image that this is peeling the outer layers of the skin, the stratum corneum is peeling away. Your differential diagnosis would be toxic epidermal necrolysis. The latter is usually due to drugs. In staph-scalded skin syndrome, the blistering is superficial and the mucous membranes are not affected. In TEN, the mucous membranes are affected with full-thickness epidermal necrolysis. Blistering can occur in streptococcal infections, so blistering can occur if the inflammation in cellulitis is sufficiently severe. Not only will there be advancing erythema, there will often be blisters associated with it. So don't be put off a diagnosis of cellulitis just because it's blistering. The hallmark will be pain, fever, leukocytosis, extending redness, and blisters may be part of that process. The worst end of the spectrum is a condition called necrotizing fasciitis, where the streptococcal infection goes deep down into the fascia and will extend. Necrosis and blistering is almost universal in this condition. Necrotizing fasciitis is both a medical and a surgical emergency. Vesicles which may coalesce into blisters are the hallmark of herpes simplex virus infection. So here you can see in both panels the vesicles of herpes simplex are both coalescing into these larger lesions, but the clustering of these vesicles is absolutely typical of HSV. The blister roof will come away, and then you often see large areas of erosions, best seen on the image on the right-hand side of the screen. Primary HSV infection can be quite large and severe. Infection can recur in the same position, though lesions are usually smaller with a recurrent herpes simplex virus infection. Varicella infection, or chickenpox, is characterised by an acute febrile illness, often associated with headache, fever, and then the development of the typical teardrop-shaped vesicles, which tend to occur particularly over the trunk and face. The vesicles will then rupture, crust, and heal, sometimes leaving a scar. After infection with varicella zoster producing chickenpox, the virus will sometimes sequester itself in the central nervous system and can sometimes later make itself apparent via an attack of shingles. This usually occurs in patients who are immunocompromised for another reason, for example in HIV. Shingles is a unilateral condition which tends to spread around a dermatome. First there will be pain, followed by erythema, followed by the development of vesicles. As you can see in the left-hand panel, there are clusters of vesicles in a dermatomal or zosteriform distribution which are coalescing to produce blisters. On the right-hand panel, you can see early lesions that haven't yet blistered. The autoimmune blistering conditions include the pemphigoid group, the pemphigus group, a condition called linear IgA disease, and dermatitis herpetiformis. In these conditions, autoantibodies are produced which eventually will cause damage to the skin, producing blistering. Bullous pemphigoid is one of the most common autoimmune blistering conditions, particularly in the elderly population. It produces a subepidermal blister, and this occurs as a result of an immune-mediated attack against proteins within the epidermal basement membrane. Bullous pemphigoid most commonly presents in the elderly. Sometimes there is a prodrome of itch, followed by a development of redness, which is also known as pre-bullous urticated erythema. This will result in large, tense, fluid-filled bullae. These can sometimes erupt, forming erosions. However, due to the deeper level at which the blistering occurs, the bullae tend to stay intact. Blisters are more common on the trunk, less commonly involving the genitals and mucosal surfaces. Sometimes bullous pemphigoid can be induced by drugs, such as gliptins used in diabetes treatment, and immune checkpoint inhibitors which are used in cancer treatment. On the left-hand panel, you can see fairly extensive pemphigoid. There are red patches on the skin, but within these areas are intact, tense blisters. In this picture, you can see pre-bullous urticated erythema, blisters, and erosions. Bullous pemphigoid is commonly seen over the trunk and limbs, but also on the feet, as seen in the image on the right-hand panel. The blisters are often hemorrhagic. As you can see in the image of the nipple, there is a large blister which is hemorrhagic. This blister has been present for a couple of months and is localised bullous pemphigoid of the breast. Again, you can see hemorrhagic blisters on the soles of the feet on the right-hand panel. Again, in the left-hand panel, you can see some pre-bullous urticated erythema with some intact, scattered tense blisters. On the right-hand side, you can see an erosion of the palate in a patient who's also had blisters over the trunk and limbs. So how do we make a diagnosis of bullous pemphigoid? Well, if we biopsy a blister, we can see that the level of blistering is below the epidermis, so this is what's called a subepidermal blister. In addition, if you look carefully at the infiltrating the dermis, you'll see that it's eosinophil rich. So this can point us towards a diagnosis of bullous pemphigoid, but the definitive test is called immunofluorescence. What we do here is take a small punch biopsy from about a centimetre away from a blister and look to see if there are any immunoglobulins or immunoreactants present at the basement membrane zone. This is called perilesional direct immunofluorescence, and what we find in pemphigoid is a bright linear band of IgG or C3 at the dermoepidermal junction. The mainstay of treatment for bullous pemphigoid is corticosteroids. If a patient has limited disease, and if practical to do so, we can use a very potent topical steroid. The main reason for doing this is that it's safer than giving elderly people large doses of oral prednisolone. If we are able to use topical steroids, this should be done daily to achieve control, after which frequency should be reduced to maintain control. For more extensive disease, we may need to use systemic corticosteroids such as prednisolone, usually starting at a dose of 0.5 mg per kilo per day, up titrating until disease control is achieved. From this point on, we would start a slow weaning course to maintain control of blistering symptoms at the lowest possible dose. We may need to use additional steroid-sparing agents such as doxycycline and dapsone to minimise the long-term side effects of systemic steroids. Additionally, if pain is an issue, we will use analgesia. If there's concern of additional bacterial infection, antibiotics should also be prescribed. The natural history of bullous pemphigoid is that in most patients it does undergo spontaneous remission, but this might take 3 or 4 years, so during this time we use the lowest possible dose of topical or systemic steroids to maintain control, cautiously reducing the dose, and eventually many patients will have disease control and can discontinue all treatments. So just returning to the pemphigoid group of conditions, there is a condition called mucous membrane bullous pemphigoid. This is also known as cicatricial pemphigoid. Cicatricial means scarring, so it produces subepidermal blistering of the mucosal surfaces in the mouth, genitals, nasal mucosa, and most importantly the conjunctiva. This elderly lady has symblepharon, that's fusion of the edges of her eyelids. There is also opacity and scarring of her conjunctiva. If left untreated, this can lead to blindness. Here are some more examples of cicatricial or mucous membrane bullous pemphigoid. The lady on the left has got inflammation of the gums. We call this desquamative gingivitis. On the right-hand panel you can see blistering, erosions and scarring of the penis. Pemphigus vulgaris is a much more serious condition. This occurs due to autoantibodies directed towards desmoglein 3 and or desmoglein 1. This results in intraepidermal blistering. Pemphigus often occurs in younger age groups than pemphigoid. Fortunately, it is rarer but has a much poorer long-term prognosis. Occasionally, it can be triggered by malignancy, particularly lymphomas. This is called paraneoplastic pemphigus. It can also be drug-induced, particularly by penicillamine, ACE inhibitors, angiotensin receptor blockers, and cephalosporins. Desmoglein 3 is present in the oral mucous epithelium, so patients often present with persistent blistering or erosions either on the mouth or sometimes on the genital mucosa. Over the course of weeks to months, blisters may also develop on the skin, particularly areas like the upper chest, back, scalp and face. Occasionally, mucosal surfaces alone are affected. Because the level of blistering is intraepidermal, the blisters are thin-walled and can easily rupture to produce erosions. So here are 2 patients with oral pemphigus vulgaris. In the first image you can see an intact tense blister on the hard palate. These rupture very easily as they are intraepidermal, giving rise to an erosion. You can see in the right hand panel an erosion at the margin of the hard and soft palate. Then blisters may develop on the skin. Here you can see some intact blisters indicated by the arrows, but the predominant lesions are the erosions which may crust, particularly if they get infected. Untreated, pemphigus leads to progression. Here we see someone with extending pemphigus over the scalp, in the ears and over the trunk. Pemphigus can be diagnosed both on standard H&E histopathology, and what we can see on the left-hand panel are epidermal keratinocytes which have rounded off and start to float away from the rest, and this is termed acantholysis. What we often see left at the base of the blister are basal keratinocytes, which stand up like tombstones. So here you can see intraepidermal blistering, acantholysis, and a tombstone basal layer. Again, direct immunofluorescence is the investigation used to confirm pemphigus, and what we see here on perilesional skin is intraepidermal intercellular IgG producing what is sometimes called a chicken wire appearance. We can also look for the presence of circulating anti-desmoglein 1 and 3 antibodies. These are more useful in disease monitoring. Pemphigus can easily be complicated by infection, particularly with bacteria infecting strep, staph and Pseudomonas. Secondary viral infections include herpes simplex. It's not uncommon to get septicemias from bacterial infection and also fungal infections. This is because we have to use quite strong immunosuppressants to control pemphigus. We try to suppress blistering by the following agents. Mainly we use high-dose oral prednisolone or can use pulsed methylprednisolone. Frequently this needs to be combined with a steroid-sparing agent such as azathioprine or mycophenolate. Rituximab has become a really important aspect of treatment over the last 3 to 4 years because it's a B-cell depleting agent which effectively reduces your autoantibody production. Wound care is obviously extremely important, monitoring for secondary infection, oral hygiene, mouth care and analgesics if required. Dermatitis herpetiformis is an interesting and fairly uncommon acquired vesicular eruption that is associated with gluten-sensitive enteropathy. It presents with herpetiform, that is, herpes simplex-like vesicles, which tend to occur on the elbows, knees, scalp and sacrum. And because these lesions are so itchy, they are very often scratched, so all you'll see are small clustered erosions. The hallmark of the condition is the finding of deposits of granular IgA on perilesional IMF. Individuals will also usually have positive celiac serology, but everyone will have some degree of gluten-sensitive enteropathy. In this image, you can see some clustered erosions on the sacrum. Here are some more clinical examples of dermatitis herpetiformis. So small vesicles on the elbows have been scratched to produce these clustered lesions, and we can see some similar lesions present on the knees. Standard histology is often unrewarding in dermatitis herpetiformis because we so seldom are able to biopsy an actual vesicle. Perilesional IMF is the definitive investigation for diagnosis. Here you can see these granular deposits evident particularly over the dermal papillae with IgA. We treat dermatitis herpetiformis by trying to eradicate the trigger, i.e. a strict gluten-free diet. Unfortunately, this can take up to 2 years to have a full effect. We would usually supplement this with dapsone between 50 to 100 mg per day will usually be extremely effective for stopping itch after around 24 to 48 hours of treatment. Some metabolic conditions result in the formation of blisters and perhaps the best known the porphyrias. The most common porphyria is Porphyria cutanea tarda. A rarer variant is variegate porphyria. So PCT is the result of a deficiency of an enzyme called uroporphyrin decarboxylase. This leads to high levels of uroporphyrins which are photosensitizing and are excreted in the urine. So high levels of uroporphyrins leads to chronic low-grade photosensitivity. But PCT is usually triggered by another factor other than the enzyme deficiency itself. These factors can include excessive alcohol consumption, excessive light exposure, and estrogens. PCT will present with fragility of the skin of the backs of the hands, so patients will often describe that they blister easily, particularly after sun exposure. The blisters break quite easily because of the backs of the hands are subjected to trauma, producing erosions which will heal to leave scars. Another thing we see commonly are tiny little white cysts called milia, which occur in the sweat ducts at the back of the hand. One other feature that we sometimes see both on the hands but particularly on the forehead is hypertrichosis, which is excess hair. Here are some clinical examples of PCT. So you can see a flaccid blister on the back of the hand after sun exposure. And on the right hand panel you can see lots of erosions and scars where previous blisters have been. Here are some more examples of PCT on the hands. No blisters are seen here, but many erosions and scars can be seen. And if you look closely, milia can be seen on the proximal end of the middle finger. On the right hand panel we can see hypertrichosis over this lady's forehead, zygoma and cheeks. We can diagnose PCT by the bedside by looking at the patient's urine. The uroporphyrins fluoresce with a Wood's light and produce this coral pink fluorescence. This produces quite a dramatic effect in a dark room. We can also measure urinary uroporphyrins. This will be hugely elevated in PCT. Ferritin can be raised in PCT due to iron overload. PCT can sometimes be triggered by hepatitis, so screening for these conditions, in addition to HIV, should form part of your diagnostic workup. We treat PCT by protecting the back of the hands from sun exposure and trauma, for example using thin cotton gloves. Reducing iron overload by venesection will often control the blistering and symptoms of PCT. If this isn't practical, we can use low-dose hydroxychloroquine. Drugs can certainly produce blisters, and in the left-hand panel we can see a hemorrhagic blister on the dorsal aspect of the hands. This patient does not have PCT as you might think in the first instance. The urinary porphyrin levels and ferritin are normal. This is actually pseudo-PCT, most commonly triggered by non-steroidal anti-inflammatories. A number of other drugs can do this. They act as chronic low-grade photosensitizing agents and produce a picture very similar to PCT. On the right-hand panel we can see something called a bullous fixed drug eruption. This patient several years ago had a course of trimethoprim for a UTI and developed a painful red inflamed area on the sole. It resolved over the course of 3 to 4 weeks, and 2 days ago they had started a further course of trimethoprim. In exactly the same area that was previously affected, the skin became red, inflamed, and ultimately blistered. This is the history of a fixed drug eruption. We can sometimes see blisters being induced artifactually by patients, which may indicate a psychological need that should be addressed. This can be difficult to diagnose. Patients can induce blisters by suction, or perhaps more commonly by freezing the skin, for example by using an asthma spray for a prolonged period of time. Finally, we see blistering emergencies. We've already talked about staph scalded skin syndrome. The other blistering emergencies are Stevens-Johnson syndrome and toxic epidermal necrolysis. These are thought to be subtypes and extensions of erythema multiforme. These conditions are almost always drug-induced and are covered in detail in the separate DermNet e-lecture on blistering emergencies.